I'm Dr. Joe Jansen with the Departments of Anesthesiology and Internal Medicine, and this video is here to serve as an introduction to airway management. We'll pretend that this mannequin is our patient and we've arrived and the patient needs to be manually ventilated. The mask is placed over the patient's nose and mouth. When manually ventilating a patient, the thumb and index finger are placed in a C position on either end of the mask, and these three fingers are used to hold up the mandible. This finger, and this finger. The small finger is usually placed at the angle of the mandible behind the ear, and the other two fingers on the mandible to lift the mandible up into the mask to facilitate manual ventilation. The other hand is used to manually squeeze the ambu bag to deliver oxygen to the patient's lungs. You'll notice I'm squeezing with the right hand. I'm holding the mask in place in a C-type position with the thumb and index finger, and the other three fingers are placed on the patient's mandible to lift the face up into the mask. We'll now demonstrate the scissor technique for opening the patient's mouth. The thumb and middle finger are used to open the patient's mouth widely. The thumb is placed on the lower teeth and the middle finger is placed on the upper teeth to really open the patient's mouth in order to make it easier to intubate the patient. This one is curved. It's a Macintosh 3-blade, which is a commonly used blade for an adult patient. This one is inserted into the mouth and into the vallecula. At that point, one lifts up on the vallecula to visualize the vocal cords beneath the epiglottis. I'll take my laryngoscope and hold it down at the lower portion of the handle. Use my Macintosh blade, insert it to the right, sweeping the tongue over to the left to visualize the epiglottis. I can now visualize the epiglottis, the arytenoids, and the vocal cords. At this point, I will place the endotracheal tube in between the vocal cords. Remove my laryngoscope blade. I will then remove the laryngoscope, remove the stylet, ensure the depth of the endotracheal tube is adequate, place some air in the bulb. At this point, you would confirm endotracheal tube depth. And at this point, I would connect the ambu bag to the end of the endotracheal tube, and myself or another person which should be available to auscultate the patient's lungs in the bilateral axilla. Then I would auscultate the stomach to ensure that I'm not hearing airflow into the stomach. I can visualize manually chest rise, and I would watch the patient's monitor and pulse oximeter to ensure that the patient's oxygen saturation were maintained or not dropping. Another way to confirm the correct placement and positioning of an endotracheal tube is to take a CO2 detector. These are usually placed on the end of the endotracheal tube and then connected to your air or oxygen source as such, and confirm that the color changes from purple to yellow. These are not foolproof, but they do provide a good indicator that the endotracheal tube is placed correctly into the patient's lungs. An LMA is generally used in the OR when a patient is breathing spontaneously. However, it is a nice rescue device. This device is placed blindly into the mouth with a pencil-pointed finger type technique. This area is lubricated. As you'll see, it also has a device on the end which can be attached to a syringe to inflate the LMA. And it is placed blindly with an index finger. Place the LMA using a pencil point finger technique, and you advance the LMA until you meet a certain loss of resistance, and this really just takes practice and multiple times of feeling the resistance. It is a nice rescue device when a patient is unable to be manually ventilated and or difficult intubation. The risks of using an LMA in general are that the patient could aspirate and have a significant untoward effect from aspiration pneumonia. An LMA, like an endotracheal tube or any other airway device, can be positioned improperly. It can fold back on itself. It can go into the wrong area, and therefore you could have placement difficulty or problems ventilating the patient. As mentioned previously, the LMA device does not protect the patient's lung from aspiration of the gastric contents. The device is placed above the vocal cords, and therefore it's called a supraglottic airway device. This then concludes the demonstration of airway management for the adult patient.